minute just for to let a few extra people join us, and then we'll begin recording shortly. California Healthcare Foundation and the University of California, San Francisco. I'm just going to take a moment to briefly review what we're doing through the SHOUT program, and then we'll get right into our presentation. So today's talk is on acute pain and perioperative management in patients who are already on treatment for opioid use disorder. It'll be presented by Kurt Geyer and Ben Smith, one of the pharmacists at San Francisco General and one of our hospitalists and primary care doctors here who does addiction medicine. We'll take about 45 minutes for the bulk of the presentation, and then at with 10 minutes remaining, we'll be answering your questions. So please, throughout the course of the talk today, be writing in questions on the sidebar of your GoToWebinar. I'll try to answer those as we go, and we'll discuss them as a group at the end. Today's speaker, our main speaker is Kurt Geyer. He's a PharmD in our emergency room at San Francisco General and at UCSF. We'll also be joined today by Ben Smith, who's an addiction medicine specialist, and will be helping to facilitate some case discussions at the end of the conference. My name is Hannah Snyder. I am a fellow of addiction medicine at UCSF, and I am the project lead on SHOUT. For the course of the webinar today, all attendees will be muted. We're going to record the whole thing, and we'll have it posted up on our website shortly. You'll also be able to access it through YouTube. Throughout the course of the talk today, we'll be referring to some guidelines that we have already published on our shared Google Drive. You can see the link here. Specifically, we'll be talking about the acute pain and perioperative management guidelines. So it'd be helpful if you can go ahead and download those so you can refer to them during the program today. Also on our Google Drive, we'll be posting our slides as well as frequently asked questions that will address the questions that are asked throughout the seminar today. If you do have a question for our presenter today, please go ahead and type it into that right-hand box. And if you have a logistical question just about how the technology is working or SHOUT in general, you can go ahead and use chat to the host function. Our goals here in Project SHOUT are to increase the access of patients to addiction medicine treatment. We know that the vast majority of patients are not currently in care, and we know that many patients access hospitals much more frequently than they access primary care or addiction medicine. Our hope is to enable you all as hospitalists to offer medications like Methadone and Buprenorphine in the inpatient setting. Our hope is that today's session will build on the skills that you've made so far by helping you figure out how do I actually manage pain and how do I do perioperative management in these patients who I have started on Methadone, Buprenorphine, or Naltrexone. SHOUT has several resources, many of which we've already referenced, but go ahead and take a look at the webinar series. All the recordings from before should be posted, so feel free to view those after the fact. You can go out and check out our inpatient guidelines as well as the patient handouts and frequently asked questions. By the end of the week, we will have a P&T sample monograph posted to our website as well, which you should feel free to download and use to present to your own P&T committee. We would love it if you could all, if you haven't already done so, fill out our needs assessment form. You can see the link there down below, and that really helps us get a sense of exactly what it is that we can do to help you guys best take care of your patient populations. And again, feel free to chat any questions to us or send us an email anytime during this presentation if you have logistical questions. We're currently in the didactic section of our SHOUT implementation, so we have one additional webinar that we'll be mentioning at the end of the session that'll be next Wednesday and covering issues of opioid use treatment in pregnancy. We've already published our guidelines. Our hope is that in January, you'll start to be building your local leadership team and working with us to address any logistical barriers that you're facing. In February and March, our hope is that our participants will start to implement and actually pilot the use of buprenorphine and methadone in their hospitals. And then April through June, we're hoping that you are able to fully go live with the treatment of patients of opioid use disorder in your hospital. So without further ado, we'd like to get things started and address specifically acute pain management in opioid use disorder. Thanks very much.
Thank you. So again, my name is Curtis Geyer, and I'm a pharmacist over at San Francisco General in the emergency department. All right, so today, some of the objectives we're going to cover. We'd like to discuss some common thoughts and perceptions about pain management in patients who are utilizing medication-assisted treatment for opioid use disorder. You can go to the next slide. We're also going to discuss some non-opiate analgesia strategies, which will be very important in managing acute pain in these patients. We'll do a little bit of the clinical pharmacology. For some of you, this is going to be a review, but we're going to try to apply it to some unique scenarios utilizing these medications. And then finally, we'll talk specifically about buprenorphine, methadone, and naltrexone, actually, and some strategies that you can utilize when you're caring for patients on these medications. So some of the common perceptions I think we hear about in patients who are utilizing medication-assisted therapy are that, one, opiate medications are not going to be effective whatsoever in patients who are chronically on medication-assisted treatment. Two, that buprenorphine or methadone themselves provide adequate analgesia with the dosing that's utilized for opiate use disorder. Three, that there's some sort of special licensing, or I'm not able to prescribe these medications for patients while they're in the hospital. Four, that buprenorphine, because of its mechanism of action, will actually block the effect of opiate agonists. And then finally, that methadone should just be discontinued in my hospitalized patients and then restarted upon discharge, just to not complicate things or exacerbate any drug interactions. So we're going to try to talk about some of these things as we go through the presentation today. So first, I think it's important to emphasize, and this may seem obvious to everybody listening, but non-opiate analgesia should really be the first line in patients who are taking buprenorphine, naltrexone, or methadone chronically. And I think these are often underutilized medications. So acetaminophen, very common, I'm sure we all encounter it, but is a very effective pain medication for a variety of mechanisms of pain. And really, scheduled dosing is recommended. So instead of using, a PRN dose or an as-needed dose for pain, symptomatic pain, we recommend actually around-the-clock dosing that doesn't require the patient to ask for it. We would also recommend against combination products. And the reason for that is this allows you, if you use something like a Norco or hydrocodone acetaminophen combination, you're tied with both the opiate and the acetaminophen together. And so if somebody requires more opiate analgesia, you may run into the upper limit of dosing for acetaminophen. So we'd recommend doing them separately. And finally, there's now an intravenous acetaminophen product available. So for patients who are NPO or you don't want to wake up to give a suppository, this allows for around-the-clock dosing that's a little bit easier. Additionally, NSAIDs, as we're all aware, very effective for a variety of pain mechanisms. There's plenty of data that shows they reduce opiate use while patients are hospitalized. A little more complicated because of bleeding risks and issues with different organ dysfunction. But again, we should at least be considering these in patients who are taking buprenorphine or methadone. There are other medications that have been studied for specifically nerve pain. Gabapentin probably has the highest quality of evidence. Again, it's recommended to do scheduled dosing rather than as needed dosing. This avoids the complication of having the nursing staff or patient have to interpret what nerve pain is or, versus musculoskeletal pain. And this can be initiated when somebody is naive to one of these medications as well. Additionally, local anesthesia. So a lidocaine patch or ointment are probably the most commonly utilized therapies. It's a different mechanism than the other medications we're talking about, so a nice option. But diclofenac also comes in a topical formulation, and that can avoid some of the systemic side effects you might get with other non-steroidal anti-inflammatories. Additionally, my practice in the emergency department, we utilize ketamine somewhat frequently. Ketamine, I guess, technically is an opiate medication, but I feel it's important to include on this list because it's a different mechanism than the other medicines we're going to talk about today. So ketamine works at kappa opiate receptors, which provide analgesia but don't add to the respiratory depression adverse effects that can happen with more mu opiate agonism. And the response you get from ketamine is kind of on a spectrum, and it's dose related. So a low dose, less than 0.3 milligrams per kilo, something like 10 or 20 milligrams, is a very effective analgesia dose with fairly limited side effects. Maybe the one downside is that the duration of effect is fairly limited as well. And then it's important to note that although I think it's an important piece of the arsenal for treating pain in these patients, there's limited evidence, particularly with buprenorphine or methadone. And so I would recommend that this should probably be utilized by somebody who has experience with ketamine, because there's some special monitoring and things in place. And then finally, regional anesthesia, things like nerve blocks are very, very effective, particularly for orthopedic injuries, and avoid the opiate receptor pathway altogether. And we've had some successful cases in our emergency department utilizing those when appropriate. Okay, so this may be a review, but it's going to be the basis for what we talk about over the next few slides. So the Y there, I want you to imagine, is the mu opiate receptor. And so our non-medication assisted treatment opiates, the traditional opiates we think of, oxycodone, morphine, heroin, they provide full agonism at that receptor. So binds the receptor, produces a full downstream signaling effect that provides analgesia. Methadone falls on that same spectrum. It provides a full agonism, but because of its unique pharmacokinetics and long half-life, it's a useful drug for preventing withdrawal symptoms in patients when we use it for opioid use disorder. Buprenorphine is a little bit different. So you'll notice that triangle is a little bit smaller. It provides less of an agonist effect. We call it a partial agonist. But it also has a tight binding affinity, meaning other opiates are not bound as tightly to the receptor as buprenorphine is. And then, of course, naloxone and naltrexone are full antagonists. They provide no effect at that receptor and will antagonize other binding. So a little bit more about buprenorphine. So because of that partial agonism effect, you actually do get some analgesia from the drug itself. And we'll talk about that a little bit more and how that can be utilized when you have acute pain. I think it's important to know that it's a competitive agonist. So really, these are concentration-based binding. And so if you increase the concentration of full agonist therapy, you're going to get more effect. But because that buprenorphine is present, somebody who tries to utilize something like heroin, or if we in the hospital try to use something like morphine, it's going to have less effect overall. Again, because it's a full or partial agonist, discontinuation, especially abruptly, will result in withdrawal symptoms, and I think that's important to know as well. So some of the pharmacokinetics and why this actually might matter. If any of you have induced somebody on buprenorphine who's experiencing withdrawal symptoms, you know that this actually kicks in fairly quickly, and that's because of the sublingual or buccal absorption. It's a fairly quick onset. Now, after you get that peak concentration in 30 minutes to an hour, there's actually a rapid phase of elimination out of the plasma. And I'm going to show this graphically in a few slides, and it might make more sense then, but we call that the alpha phase. And it's basically where concentrations decrease rapidly because it distributes from the plasma out into the tissues. And then once it's distributed out into the tissues, that half-life turns into a far longer period, which allows for daily dosing for opioid use disorder. So you get this short time where you have sort of a peak concentration or a higher concentration. And then over the next 20 to 40 hours, you have a low level of drug in the body and in the plasma that helps prevent those withdrawal symptoms, but doesn't have any added side effects. Now let's contrast that with methadone. So methadone, of course, is a full mu opioid agonist. And so when you add additional full agonists to the presence of methadone, instead of them being competitive, you actually get an additive effect. And that's important to know when we manage pain. So all of the positive effects, things like analgesia, will be additive, but also the negative effects. So constipation, respiratory depression, those things will add on top of each other. Additionally, methadone, because of its full agonism, will induce a little more tolerance to the analgesic effects. That's important to note. And then, of course, if you abruptly discontinue methadone, it will result in a withdrawal syndrome. So contrast to buprenorphine, the pharmacokinetics of methadone are a little bit different. So because of oral administration, absorption via the gastric system is a little bit slower than the sublingual system. So your peak here is about 3 or 4 hours. But again, you have that dual phase elimination. This time, the alpha elimination phase lasts between 8 and 12 hours. That's that rapid decrease in serum concentrations. And then the beta elimination phase is much longer, and it actually becomes longer with continued dosing. And I won't cover it here, but because of these pharmacokinetics, this will actually dictate how we induce people onto methadone, or how we initiate people onto methadone. All right, so this is a curve that I'm sure some of you have seen before, but we're going to talk about it a little bit differently today in the context of providing analgesia. So you can see that, again, methadone lies on that full agonist line. Buprenorphine has what we think of as the ceiling effect, so you don't get the same degree of opiate effect. But if you'll go to the next slide, this green zone we have here is really where that analgesia will happen. It's going to happen at the higher level of opioid effect. And so because of this, you can assume, you see that those lines fall within that green zone. These are analgesics. These medications do bind to opiate receptors and thus provide some analgesia. Both of these have been utilized and studied for chronic pain, and we have plenty of experience with that, but it's important to know that dosing for pain cannot be done daily. So daily dosing of either buprenorphine or methadone does not provide enough analgesia for acute pain, and I'll illustrate that in a second. This is primarily due to a few factors. So first of all, the pharmacokinetics. So I mentioned that alpha phase and beta phase. I'll illustrate that in a second. Second, both of these medications to differing degrees do induce some tolerance. You have binding of opiate receptors chronically, so you will have some upregulation of opiate receptors. These patients will be used to that effect of an opiate, so higher dosing may be necessary. And then third, there's this idea of opioid-induced hyperalgesia. So chronic exposure to opioid medications actually changes the perception of pain, and thus you may have a greater or an altered pain response in patients who are chronically on these medications. So because of all of this, we can alter how we do the dosing for these medications, and we'll talk about that in a second, but it's possible that other pharmacotherapy is necessary and other opiate therapy is necessary. All right, so this is a very pharmacist slide, but what we have here is a concentration versus time curve for Suboxone. So you see that solid line with the square boxes, that is the buprenorphine concentration following administration of a Suboxone tablet at time 0. The dotted line below that is norbuprenorphine. It's an active metabolite of buprenorphine, and you can see it just trails the buprenorphine concentrations. And then, of course, naloxone is not readily absorbed, and that's the bottom line there. So what I want to illustrate here is that you get this big peak following the administration, and then you have this initial rapid decrease in plasma concentrations. That is what is the alpha phase, that initial 8-hour period there where concentrations are higher than they are for the rest of the day. That is what we can utilize for the analgesic properties, if you want to go to the next slide. So this window is when buprenorphine can provide some analgesic activity. So following this graph, if you were going to provide buprenorphine for acute pain, we would dose it 3 times a day. So if somebody's on daily dosing, you can switch them to TID, and we'll talk about some strategies there, but we're relying on this higher than usual concentration to provide that analgesic effect. So on the next slide, you'll see it's a little bit messier, basically because this study was done quite a long time ago, because methadone is an older drug. What you can see here is, again, at time 0, you have administration of different methadone tablets that are labeled for measuring concentrations. Also, the y-axis here is a little bit adjusted, but the point stays the same. These peaks that last about 8 to 12 hours with methadone are when we get that analgesic effect. And so if you're going to dose methadone for pain, it must be dosed more than once a day. All right, so if you want to go to the next slide. So when you have a patient that you're treating for acute pain who's chronically on buprenorphine, here is what we would recommend. So the first thing is that if at all possible, we recommend to continue the buprenorphine. I'll emphasize this a little bit later, but it's important to only sort of change one variable and also not create an opiate deficit when managing pain for these patients. There's no need to decrease the dose, but you can actually split the dose. So again, I was emphasizing that 8-hour higher concentration time frame. So if a patient's taking 12 milligrams daily, You could imagine splitting that to 3 times a day. You can make it 4 milligrams sublingual TID. It's the same total amount of buprenorphine, but this allows for you to take advantage of those short terms of higher concentrations and get a little bit more analgesia out of the drug. Buprenorphine, one of its strengths is that it actually has the ceiling effect, though, and so it's possible you may need to use opiates on top of it. As for all of these cases, we're going to emphasize that this should be part of a multimodal approach. You should be providing non-opioid analgesia or regional anesthesia whenever appropriate or whenever you can, and that opiates are only one piece of the controlling pain in these patients. So because of the competitive binding, higher binding affinity of buprenorphine, it's important to know that these are patients who are going to require higher doses. So if you would have normally started somebody with 5 or 10 of oxycodone or 4 or 8 of morphine, it's important to know that you are going to have to give higher doses. So consider something like 15 to 20 of oxycodone or 10 to 20 of morphine, and at the very least, reassess more frequently and adjust your dosing if necessary. So you may be asking, why would I complicate it? Why would I provide the patient with this partial agonist that's going to make utilizing full agonists a little bit more challenging? Well, the first thing is that it doesn't actually make it more challenging. You're able to provide analgesia from opiate agonists in patients who are on buprenorphine. This has been studied, and it is effective to utilize full opiate agonists when buprenorphine is present in the serum. Again, it's important to know that higher or more frequent dosing may be necessary, and also you should continue the same buprenorphine dose. So if you can imagine you have buprenorphine present in the system at a certain level, that's providing an amount of competition with that full agonist that you're going to be redosing. If you start to decrease the amount of competition or decrease the amount of buprenorphine present in the serum, you're going to expose the patient to more full agonism as the timeline goes on, and thus there's a risk for overdose. Separate from that, by continuing the buprenorphine inpatient, you're going to prevent the risk of overdose or relapse when the patient gets discharged. So you're still providing them with the safe medication that they've been stabilized on and are used to, and so you're reducing that risk of relapse. And then finally, you're avoiding the need to re-induce these patients on buprenorphine before they discharge, which would, if you do stop it, would be the ideal scenario. So in that scenario, you've taken them off of buprenorphine, initiated full agonist therapy, and now the patient is tolerant to full agonist therapy. You're going to need to wean them off and have a washout period of the full agonist before initiating buprenorphine again. Otherwise, you run the risk of precipitated withdrawal. So all of this just points to, when at all possible, continue buprenorphine and then add on therapies on top of it if you need to. All right, so just to kind of illustrate this pictorially. So you see the buprenorphine, that half triangle binding to that receptor. Again, this is a competitive binding, meaning all you have to do to get more of that full agonist activity to shift where we're at in that green analgesia box is to increase the concentration of your full opiate. It's not going to all of a sudden displace all of the buprenorphine and then you're going to result in respiratory depression. These are purely on a gradient, so it's all concentration based. I think it's important to know that short-acting opiates are recommended, mostly so that you can reassess and constantly adjust your dosing. These are not the straightforward pictures that many of us are used to. So short-acting, adjust your dosing more frequently. So again, this is illustrating that your goal is to, if somebody is living on the partial agonist line, that's the amount of opiate effect that we're getting out of our buprenorphine, and if it's not enough for this acute pain period, we're going to increase the concentration of the full agonists. That line says methadone, but again, morphine, oxycodone live on that as well. And we're going to find ourselves somewhere between those two lines as those concentrations compete, as those drugs compete at the site of the receptor. Now, although not recommended, if you do need to discontinue buprenorphine, say for a major surgery, an elective surgery where you have time to think about this, it is recommended to taper it over a long time period. So acute discontinuation of buprenorphine, again, runs that risk of potentially overdosing the patient as concentrations of buprenorphine decrease and you're adding full agonists on top of that. Also, rapid tapers can result in withdrawal symptoms and thus an increased risk of relapse. So these are plans that should be carried out over a longer time frame. As you are decreasing, or as the serum level of buprenorphine decreases, their opiate requirements will actually vary. So initially, as the buprenorphine concentration is higher in their system, they will require more full opiate agonists. And then actually, as buprenorphine goes away, patients will require less. So it's a little counterintuitive to what we're used to. Basically, what that means is these patients should be monitored closely. And then, of course, if you discontinued it, it's recommended to try to titrate the patient back to their pre-discontinuation dose, back to their home dose prior to discharge. And of course, this should be done after washout of the full agonist to prevent precipitated withdrawal. Again, to utilize our favorite opiate effect curve here, precipitated withdrawal would occur if somebody was on a full agonist. Say they came in for an operation, we had discontinued buprenorphine, and thus they've been stabilized on a full agonist, and then we started buprenorphine. That can obviously precipitate withdrawal. So it's recommended, when possible, to continue it throughout the hospitalization. All right, so let's talk about methadone a little bit. Now, in addition to continuing buprenorphine, we would actually recommend to continue methadone when at all possible. There are regulations to using methadone for opioid use disorder, namely you should be enrolled in a methadone clinic as an outpatient, but as an inpatient, we can continue patients on their methadone treatment without restriction. It's important to contact the patient's methadone clinic, both to verify their dose and just make sure they've been coming in, but also to communicate that they won't be coming in. We're going to be giving them their methadone in the hospital for a few days. Lastly, I think it's important to know that methadone for opioid use disorder does not appear in cures or any prescription drug monitoring program, so that contact with the clinic is absolutely necessary. Again, cannot emphasize this enough. Please utilize non-opioid analgesia in all of these patients and regional anesthesia whenever necessary, or whenever possible. So again, those pharmacokinetics, again, that alpha phase, that short period of an increased concentration, allows for dosing to be split, TID, and again, taking care of that analgesic property of methadone. And then on top of that, these patients can be treated just as somebody who is opioid tolerant. They have exposure to a full agonist over a long period of time, but the side effects with the opiates you're going to be prescribing will be additive. So particularly, methadone is a risk factor for sleep apnea. And even though that 8-hour time frame provides that analgesia, it's important to know that methadone is in the system for the full 24 hours. So again, short-acting opiates are the way to manage these patients because you'll be able to adjust as necessary as the pharmacokinetics of methadone change throughout the hospitalization. Unique to methadone, especially compared to buprenorphine, are some drug interactions. So one major one that is really more of a pharmacodynamic interaction is, if possible, avoiding benzodiazepines. So benzodiazepines on top of methadone are a significant risk factor for respiratory depression. And again, we may not think of it because the patient isn't actively showing signs of opioid intoxication, but methadone is present in the system 24 hours a day. And so if at all possible, avoiding benzodiazepines may be necessary. Now, there are a variety of drugs that either increase serum concentrations of methadone or exacerbate the QT prolongation that we see with methadone. And it's not really something that absolutely needs to be avoided. We list these things here really just to make you aware that this is something that happens and that monitoring may be necessary. Monitoring EKGs when a patient comes into the hospital or when you start one of these additional therapies might be necessary just to ensure you don't have too much QT prolongation. To that end, one of the reasons that methadone should be discontinued or held for is extensive QT prolongation, or of course, if a patient seems sedated or intoxicated. But in most scenarios, we would recommend continuing it. All right, let's go back to our receptor binding. So instead of the competition we had when we were utilizing buprenorphine and then adding on a full opiate agonist, these are going to be additive. So they bind the same receptor, but the effects you're going to get will be additional. So that's great in the case of analgesia, where you want to shift ourselves up in that green zone and provide more analgesia, but it's important to note that the adverse effects, again, respiratory depression and constipation, will be additive as well. This is just an example of a scenario where somebody is on a maintenance dose of methadone, and again, we just need to shift up our opiate effect, and this can be done utilizing short-acting opiate agonists without difficulty. Now, I mentioned opiate deficit before when I was talking about buprenorphine. Imagine a case where somebody's stabilized on 80 milligrams of methadone a day. If they come into the hospital and we remove that opiate binding effect, we now have to compete with the withdrawal syndrome and the opiate deficit. Remember, these patients have upregulation of mu-opiate receptors. And so we have to occupy both their withdrawal and the increased need for analgesia. So if we go to the next slide, you'll see this represented graphically. In this scenario where you've removed either the methadone or the buprenorphine, you've put yourself down on this bottom line, and now you have to make up for both the deficit and withdrawal on top of their increased need for analgesia. And so, although I think sometimes these are thought of as complicated scenarios where somebody's on methadone and you're managing pain, really it's a lot simpler to sort of add only one variable into the equation, which is your short-acting analgesia medications. If you provide that baseline of the methadone they're already on, you're not having to make up for that deficit. So finally, naltrexone we didn't mention a whole lot in this presentation thus far, and that's predominantly because it's a little more complicated and a little less utilized, I would argue, routinely, although hopefully we'll see it more and more. So naltrexone is an orally bioavailable mu-opioid antagonist. The dosing dictates that it can be done daily, so you may have patients who take this orally daily, or even every other day. There's also a monthly intramuscular injection, and so it's important to try to clarify what these patients are actually taking. You know, a patient may not mention that, oh, I get an injection once a month, but that's definitely going to affect your ability to manage acute pain if somebody is receiving naltrexone injection. So the way to think about this, I think more people are familiar with naloxone. This is just orally available naloxone. And so if you have mild to moderate pain, again, make sure to utilize that non-opiate analgesia. That's going to be the biggest benefit you can get. Regional anesthesia, if available. And it's important to note that contrasting with the other two medications, buprenorphine and methadone that we've talked about, these patients are not tolerant to opiates. So they have had an antagonist binding to that receptor and thus have had no mu-opioid agonism present. And so if you start utilizing opiate medications when somebody has naltrexone in their system, you're going to have to outcompete the naltrexone, but once the naltrexone goes away, the patient does not have tolerance whatsoever, and there's a significant risk for toxicity. And so these are patients who need a tailored plan. They need close monitoring. Now, if you do have anticipated severe pain or a planned surgery, it is recommended that you can discontinue the naltrexone either 3 days prior to the surgery, in line with that every other day dosing, or discontinue their prior injection of the long-acting injectable. And you can utilize the PO therapy up until 72 hours prior to the surgery. So let's readdress some of these perceptions, these common thoughts about pain management in patients who are taking medications for opiate use disorder. So first of all, the idea that opiate medications are not effective in patients taking buprenorphine or methadone, and that's just not true. Opiate medications are effective and may be necessary in patients who are having acute pain and can be utilized safely in patients on buprenorphine or methadone. Next, buprenorphine and methadone are analgesics. These are opiate agonists that provide some amount of analgesia with dosing used for opiate use disorder. And I think we know now that's not true. So daily dosing of methadone or buprenorphine is inadequate for analgesia. These are effective analgesic medications, but they require at least TID dosing to take advantage of those pharmacokinetics. Next, special licensing is required to prescribe these medications for hospitalized patients. Also not true. Patients who are admitted and taking buprenorphine or methadone, they can be continued on the inpatient side without any additional licensing whatsoever. Once the patient becomes eligible for discharge or ready for discharge, they may require a buprenorphine prescription or communication with their methadone clinic to coordinate that discharge. Next, buprenorphine blocks effects of opiate agonists. That's kind of true, although I think the important part is that it doesn't block the analgesic effect. If you utilize higher dosing, if you outcompete the agonism of the buprenorphine, you will be able to provide adequate analgesia using opiate agonists for patients on buprenorphine, and buprenorphine should be continued because of that. Lastly, methadone should be discontinued upon hospitalization and then restarted once the patient is discharged. This is not true as well. For one, you're going to create an opiate deficit and thus have to outcompete and add on to their deficit to create that period of analgesia. And then on top of that, by continuing the medication-assisted treatment utilized for opioid use disorder during the inpatient stay, you can minimize the risk of relapse and also complications of full agonist therapy.
Okay, so thank you so much for Kurt. This is Ben Smith. I'm going to be running through a few different cases. We'll do them pretty quickly because I want to make sure we have time to go over some of the great questions that people have written in. So going to our case number one. So the purpose of these cases is to sort of trigger you guys to think about, well, one, what would your next step be after reading this? And two, to think about how you tie it back to some cases of your own at home that you may want to write in questions about. So the case number one, the conundrum, this sort of represents the central problem that we're dealing with a lot of the time. A 38-year-old male, previously with heroin use disorder, now doing well on buprenorphine and naloxone. Earlier this week, he sustained a serious fracture of his foot and is going to have surgery this afternoon. Currently, he's inpatient. This is an actual call that I took on our substance use swarm line. So the caller was actually the primary care doctor who was treating the patient for opioid use disorder. So the caller, the primary care doctor, was called by the inpatient attending stating that the patient is quote, pain med seeking. Pain control during the hospital stay has been, quote, a disaster. And they've given him 5 milligrams of hydromorphone over the course of the last day only. And he's having full body pain now, likely withdrawing, suspects that his COWS opiate withdrawal score would be quite high. The hospital is not increasing the hydromorphone dose and will not discharge the patient post-operatively with opioids. So the patient himself is quite upset and terrified of being prescribed anything other than his maintenance buprenorphine naloxone, and specifically worried that they're going to prescribe him oxycodone on discharge, as this was the main part of his opioid use disorder relating to oxycodone originally. So what is your next step? So maybe we'll go, Sarah, to open up the poll. Okay, so I'll read through the different options. So option number one is stop buprenorphine and start IV opioids. Option number two is split dosing of buprenorphine. Option number 3C is IV opioids and split dosing of buprenorphine. D is non-opioid pain medication and split the dose of bup. And finally, switch to methadone for better pain control. So there's no single right answer, but I'm interested in what people would vote in terms of what their first option, their first try would be here. Good, so the results are coming through. So let's see, almost 75% of you guys have voted. So most people are saying D, non-opioid pain medication and split the dose of buprenorphine. So that's great, it's a good option and a good place to to start. And so the other two that people chose were option B and C, and those are also good options. I think it's a question of where you would want to start, and I think I agree that D would be the best place to start with non-opioid options, as Curtis emphasized so much. But I like the fact that people are also choosing split dosing of buprenorphine, because that really gets at the effect of extending the pain control effect of buprenorphine through the 24-hour period. So needing to split it BID or most often TID in order to cover somebody for pain control. I like that nobody selected A. Good job. So we'll move on to the next case. Before we move on, I do just want to say that this is a really common call that we get where I haven't touched on many of the issues in depth, but where the hospital, you can hear some of the frustration in the caller's voice in this case, but often the hospital is just simply not familiar with buprenorphine. So I think a lot of their decisions in managing this patient comes out of that lack of comfort. And so they don't prescribe it, and they kind of go back to what they know how to do, which is to try to treat acute pain the way they know, and also they have a fear of causing more problems for the patient in a patient with an opioid use disorder. So I think a lot of the issues that come out of this case are just from lack of comfort with the medications. Okay, so case number 2 here, a case of mild pain, could even be an outpatient case, a 62-year-old female on buprenorphine naloxone maintenance with monthly visits, so she's doing pretty well. She's had successful treatment so far, has a history of opioid use disorder. This one was on prescription opioids. On a monthly visit, the urine toxicology screen or urine drug screen was as expected, nothing surprising there. She fell this weekend, dislocated her shoulder, went to the ED, and had her shoulder reset, and was prescribed 20 tablets of Vicodin or hydrocodone on discharge from the ED. She's reporting 10 out of 10 pain 1 hour ago. The pharmacy won't fill the Vicodin due to the buprenorphine naloxone prescription. What is your next step? So if we can bring up the next poll. And there, the poll is open. So option number 1 is to stop the buprenorphine and start hydrocodone alone. Option B is to advocate to fill the buprenorphine to the pharmacy if they're amenable and split the dosing of the buprenorphine. Option C is adding hydrocodone in addition to the split dosing of buprenorphine. Option D is add another opioid, that's what it should say, other opioid medication on top of the buprenorphine. And then E is non-opioid on top of buprenorphine. So this one, I'm interested to see what people say. Okay, so again, we have, well, more people filter through here. We've got about 50%. It's fun to watch the answers trickle in. So now we've got 66% of people responding, and we're pretty widely split between B, C, and E. So that's kind of cool. So either advocating to fill the buprenorphine as a first step, adding hydrocodone in addition to the split dosing, or adding a non-opioid medication on top of buprenorphine. So I think everyone agrees that trying to continue the buprenorphine at this point is a good idea, and then it's just a matter of what you're trying to add on top versus trying the split dosing alone first. And I agree, I think I probably would try split dosing as a first option, because it's always better to use less medications if possible. And you'd be amazed what you see when you actually split the dosing TID and how different the pain control is. Okay, great. Last, well, possibly the last case. Let's see what time it is. Yeah, we may leave some more time for questions. So this will be the last case. So this is a case with severe pain. So 50-year-old male on 24 milligrams of buprenorphine, 8 milligrams of naloxone with acute pancreatitis. Patient was at a treatment center and was stable. We don't know how long he's been on the buprenorphine, but it's been more than a few months at least. Then he developed severe abdominal pain and was admitted to the hospital. The caller who called into our warm line wants to tell the hospitalist how to use the buprenorphine naloxone for pain, though they may have already started a different opioid agonist. So what would you say? What if you were advising the hospitalist on what to do? Would you tell them, stop buprenorphine and start an IV opioid? Split dosing of the buprenorphine, IV opioids and split dosing of buprenorphine, a non-opioid pain medication and split dosing of buprenorphine. And this is a case of severe pain, remember, or switch to methadone for better pain control. Great, so most people are saying C, option C, IV doses of other opioids and split the dosing of buprenorphine. And I agree that probably, as we all have learned, the management of acute pancreatitis usually involves IV pain medication. And so I think that probably is a reasonable expectation for what to do first, although I don't disagree with the people that chose the other two common options, B and D. So, in summary, just a few little things that these cases reflect that going back to what Kurt was teaching us, you really don't want to put a patient in an opioid deficit by withdrawing all of their medications, as we saw in the first case that was happening. Doing that makes you have to treat with acute pain medications to make up that deficit. And then on top of that, treat the acute pain. And again, just having opioid agonist therapy in the form of methadone or buprenorphine does not mean that other acute opioid treatments can't work. So with that, I'm going to turn this over to Hannah to start addressing some of your great questions.
Great, and we do have quite a bit of time left for questions, so go ahead and put those in through the question panel on the right side of your screen. Just to review briefly while you're getting those last questions in, go ahead and email us. Here's our Project Shout overall email at projectshoutcoalition@gmail.com. Please go ahead and send us emails there if you have any questions or concerns, and please do fill out our needs assessment and sign up for our program. We'll be sending you an email in the next couple of days with our frequently asked questions, as well as our slides in both PDF and PowerPoint format. Based on the questions that you guys are asking, we'll also be sending out research articles that are backing up the statements that we've been making. And then please do go ahead and register for our next webinar. Normally they're every 2 weeks. This time we're doing it a little faster to make up for the holidays. So webinar 4 on buprenorphine and methadone management in pregnancy will take place next Wednesday from 12 to 1. So we're going to go ahead and open it up for questions now. And we've had some really excellent pharmacy questions that I'm hoping that Kurt can answer for us. So the first question is actually addressing something that came up in our last webinar, which was the euphoric blockade effect of methadone and buprenorphine. So in patients who are already on methadone and buprenorphine, who then use illicit opioids on top of that, try to take heroin or something on top of that, how does that blockade work, and why do patients not feel that euphoric effect?
That's a great question, and so we don't have to go back to the slide, but I want you to imagine that opiate effect curve. And so the euphoric effect that you will receive from getting an opiate is due to that change of where you live on that curve. It's a change from going from, say, 0 opiate in your system to a higher level of opiate. That's going to give you both some adverse effects, but also that euphoric effect. So it's a little bit different between why that is not the case when somebody's on methadone and compare that to buprenorphine. It's a little bit easier to understand in somebody who's on buprenorphine, and that's just that buprenorphine in the setting of full agonists, something like heroin, is essentially an antagonist. You are that purple line on this graph is bolder in a sense. That buprenorphine is bound to that receptor and will not come off until you provide a much higher amount of opiate there to displace some of the buprenorphine. So in that sense, it's just an antagonist effect to the full agonist, if that makes sense. Now, in the case of methadone, somebody's already on this curve. So they've already actually, they're starting from a point further up this line, and thus the amount that they will increase themselves on that line when they receive another full agonist is less so. So that's partially a tolerance effect, but partially it's just that even though methadone has this peak and then a much longer tail, they've always got drug in their system. They've always got some amount of binding to that mu-opiate receptor, and thus you don't get that big jump resulting in the euphoric effect. Does that make sense?
Great. I think that's a great answer. And we also, Kurt, see some differences in the euphoric blockade depending on the dose of methadone. Is that right? So at higher doses of methadone, you see more of a blockade?
Excellent. Yeah, and that's following that kind of the same idea on this graph. If you have a higher dose, right, if people are on a higher dose of methadone, you just already have more binding present, and thus you don't get the euphoric effect from a bunch of extra full agonist binding, if that makes sense.
And this is Diana, and Kurt, you should correct me if you disagree. My sense is, too, that we're talking about different receptor subpopulations in some of these cases. Like our image of how buprenorphine works as a partial agonist probably isn't totally complete, because it looks like it may actually be a pretty effective agonist for some of the analgesic effects of opioids, but have less of an agonist effect when it comes to the euphoric or respiratory depression effects. And so I think part of it is that it behaves differently on some of the analgesia subpopulations than on some of the other subpopulations.
One other thing. This is Ben. One other thing is just to, and Kurt, you may have said this, but just to keep in mind that the euphoric effect, the pain effect, and the long tail withdrawal prevention effect all have different sort of half-lives, with the euphoric effect being the shortest. So that's just something to kind of keep in mind, I guess, pharmacologically, pharmacodynamically, in terms of why you see people using these medications differently for different effects, different amounts, numbers of times per day.
Okay, our next question that's come up a couple times is about the mu receptor binding affinity of the different opioids. So the question is, I've heard that fentanyl and hydromorphone have similar mu receptor binding affinities to buprenorphine. Does this mean that these opioids are more effective in the presence of buprenorphine than other opioids are?
This is Kurt. I'll take an initial stab at this one. So it is correct that fentanyl and hydromorphone are more potent agonists at the mu-opiate receptor. And the way to think about that is when you give somebody a fentanyl dose, the dose is far lower, right? It's in micrograms, as opposed to when you give somebody a morphine dose and it's in milligrams. And so we sort of account for that differentiation in the amount of agonism you get. That said, buprenorphine, for the most part, is still a tighter binding affinity than both of those other medications. So while those are more potent agonists, you will still need higher concentrations to compete with buprenorphine present.
Great. We have a question about buprenorphine patches and what to do perioperatively with that. So if a patient is on a buprenorphine or Butrans patch prior to surgery, would you continue that patch?
So this is Kurt again, and I apologize if I'm stepping in on anybody. I actually think that is the perfect time to continue the therapy. For one thing, you avoid the need to administer the medication sublingually, but additionally, for those that aren't familiar, a buprenorphine patch is a weekly patch. And so once you deposit that drug transdermally, even when you remove the patch, you have a big delayed amount of drug in your system. And so because of that, titrating people on or off of patches takes a long time. And so I would actually recommend leaving the patch there, if at all possible, keeping it on the same dose, both because if you adjust the dose, you're not going to see that effect for weeks, but also because you're not inhibiting your ability to give any other opiates with that transdermal patch present.
And just to tack onto that, we deal with this situation quite a bit. And I think one thing to keep in mind that's important about the buprenorphine patch is that the doses, just like with the fentanyl dosing, the doses are in micrograms. They're significantly smaller doses overall. Even when you add up over a 24-hour period of time, keep in mind that the dosing is in micrograms per hour. But even over that 24-hour period of time, they're much lower than the sublingual dosing of buprenorphine. And so that gets at why it's easier to treat with other opioids on top of a buprenorphine patch than it is, for example, sublingual films, where you're going to probably need higher doses of these other pain medications to achieve the same pain effect. And just so people know, the patch is approved for pain. It's not approved for opioid use disorder treatment.
I just thought of one other consideration, just since we were talking about pharmacokinetics. I do think it's important to know that when you do the sublingual dosing and you get this big peak followed by rapid decrease in the systemic concentrations, that doesn't necessarily occur with the transdermal patch. Essentially, you're holding the concentration solid, and so you're not going to have higher or lower concentrations throughout the day. Again, just making it a little bit easier, actually, to titrate analgesia because you have a stable concentration in the serum throughout the day.
Great. The next question we have is, and I think either you can answer this one, why does precipitated withdrawal only happen when you have a patient on methadone and then give them buprenorphine, and not happen when you're going in the other direction from buprenorphine to methadone?
I can take a stab at that, although I'll probably use less technical language. But if you think about the fact that buprenorphine is a much stronger binder to the opioid receptor in general, you can imagine a person's receptors being saturated with methadone or another opioid, really, of any other kind. And then suddenly a bunch of buprenorphine is introduced to their system. And and when that happens, buprenorphine binds really strongly, so it knocks off that other opioid, most of which have a stronger effect, as to be distinguished from a stronger binding. So buprenorphine has a stronger binding, but in general, it's less potent in terms of its opioid effect. So when that other opioid is knocked off by buprenorphine, they're experiencing a relative withdrawal. Whereas if the order is reversed and you're introducing methadone after buprenorphine or any other opioid after buprenorphine is so strong binding, it's already bound to all those receptors as long as you have an adequate blood level. And then you need quite a bit more to outcompete the buprenorphine. So it's much more of an incremental effect over time as you increase the dose of that other opioid. It doesn't knock the buprenorphine off all at once, like buprenorphine does to other medications.
One of the ways I've heard people describe it is if you imagine a light dimmer, when somebody is on methadone, the light is on all the way bright. When somebody's on buprenorphine, it's on half bright. So if you go into a room where the light is all the way bright and you bring it down to the buprenorphine level, it feels like you've darkened the room, which is the experience of withdrawal. Whereas if you're in a half dark room and you put methadone in there, you're just brightening the light, which is kind of the opposite of withdrawal.
Great. I like that metaphor. I haven't heard that before. I think we have time for one more quick question. So this is something I hear pretty commonly. Some patients on buprenorphine naloxone for just opioid use disorder, not for pain, seem to prefer BID or TID dosing. Why is that, and how can we understand that?
I'll take a stab at this one, and welcome other ideas. Partly, I think we don't know, honestly. Some people, like I deal with people who are pregnant, who often do seem to experience some withdrawal symptoms towards the end of the day if they don't split their dose I don't know if they're fast metabolizers. I don't know if it's because people just feel like the placebo of taking something every once in a while is helpful for them. Maybe they are treating some pain with it. Um, I don't know that it's entirely clear, but I do feel fine about it. I know there are some people who feel like you have to force patients to take it once a day rather than TID because there's something sort of addictive about taking it multiple times a day. I really don't think. I think people are going to take the medication as they take it, and as long as it's keeping them from using illicit drugs and helping them build their life back together, it's fine if they take it TID.
This is Kurt. If you could do me a favor and go back to that buprenorphine concentration curve slide. I know it's way back there. So the way I actually think about this is that although we say that these, textbook half-lives are 20 hours or 24 hours or whatever number you read, these are a little bit interpatient variable, right? So some patients, as Dr. Crawford just mentioned, will actually have withdrawals feelings and withdrawal symptoms, even if they're not necessarily as drastic towards the end of the dosing interval. And so you could imagine if you just took the peak of this curve, made it a third of high, and then spaced it out every 8 hours, you're going to never have as low of a concentration as you will at hour 24 on this graph. And so I know there's a presentation coming up about use of these medications in pregnancy, but some patients are just rapid metabolizers, and these are hepatically metabolized drugs, and people may clear them faster than others. And so there is a segment of the population that will need more frequent dosing even for opioid use disorder. But also, you will get a little bit more of that peak, and that may be more comfortable. Again, people may be managing a component of pain with that as well.
Great. Thank you so much to all our panelists. I believe that's all the time that we have for today. We'll make sure to get to the rest of the questions that you all asked in our frequently asked questions document and send that out to you shortly. And we hope to see you next week on our webinar on buprenorphine and methadone in pregnancy. Thanks very much.